So first, thanks for joining. I know it's a big day for you today, so I thank you so much for joining us. But ONC, part of HHS. For those of you who are, people in the audience that don't know, who are you and what is ONC, and walk us through a little day in the life.
Sure. How many people know what ONC is in the room? Okay. So ONC is the Office of the National Coordinator for Health IT. We are 18 years old. We've been around more actively since 2010. So you have probably know us because of your health information. So your patient portals, your health records, everyone's been talking about it. I'll touch on the dental use case in a few minutes, but the Office of the National Coordinator for Health IT in 2016, the 21st Century Cures Act was rolled out by Congress. So again, hopefully some of you remember that and are aware of what those laws provided and enabled for you as a patient. But what you might not know is the technical component of that initiative. It was very much, at least the way people talk about it now, is a little bit buried. What technical capabilities were required in that legislation, and it's the use of APIs, so application programming interfaces. You wouldn't think twice about the fact that that technology is available when you come here to this conference to book your flight, to get into your banking information, your financial information. But when it comes to healthcare, it is very difficult to move information. And what I do is run the Office of Technology, or help run the Office of Technology, which manages a certification program that I think that officially rolled out in 2010. And what we do is provide the conditions of certification that all developers of certified health IT have to attest to. So that means what technical functionality are they making available, what capabilities, whether it's for the provider or the patient-facing functionality, and making sure that there's a conformance process in place so that as we put out new regulations, the most recent one, why today's a big day, it's the mark of the deadline for the 2-year glide path for all technology vendors to make sure that their providers, and I'm going to say this way very specifically, to help their customers, providers, make information more readily available to their patients via their portals in most cases. And this is playing out. It's very complicated, and we can talk more about that. But it also, as some of you, I saw somebody from CVS here, but some of the work we do is make sure that adopted standards that have already been tested and proven to be scalable and actually helpful to both the patient and the provider. There is a smart scheduling spec, so smart health cards, which is the basis by which the Apple Health platform operates, and this was actually born in part here at Boston Children's Hospital with Dr. Ken Mandel and Josh Mandel from, I might be mixing up the pronunciations of their name, I always get it wrong, but that work is just one of the different types of health standards that my team and our organization help with partner standard development organizations. Again, this is very much under the hood, as it were, so a lot of people don't realize that it's really complicated.
And it's part of HHS, is that
Yeah,
correct?
we're Astaptive as part of HHS. We are required by Congress to fulfill certain regulatory statutes, and then we do that with a policy team and a tech team.
In terms of why today is important and just diving into sort of what you're talking about exactly, is that in regards to if specific vendors or hospital or whoever it is might have an open API and I'm on my app, that it's regulating that and that there has to be. So why is today important in regards to sort of exactly, the data? Where's that data coming from,
Yeah,
and is
sure.
it me as a consumer?
Yeah, so there's two key things. So one, and I'm going to high level it, but people want to ask detailed questions. There's also a dearth of information on our website for those who really want to become an expert. But we established a floor called the U.S. Core Data for Interoperability, and that was required to be made available a few years ago. That's the baseline. So that helps to make sure, from our perspective, we are not going to require a certain data element be something that providers have to capture at the point of care if it doesn't make sense for improved patient access to information and ultimately to improve the medical outcome. However, the way that information is captured and then how it moves, that's increasingly becoming complicated. There's lots of different ways of doing that. There's the different standards, and I'll give an example of why this is important for us as patients to care about, but how then that the vendor, the EHR vendor, make sure that information can appear for both the doctor at the point of care and then later for the patient. The complexities that are playing out now are just to directly confront it. Just what some of you probably are dealing with in your companies or in your professions are, okay, if I'm giving a diagnosis, if I'm a specialty provider and I have to give somebody hard news or difficult news, then I need to be able to control the way that notification goes out to the patient. And those are all things that are absolutely understandable. But our job is to make sure that you as the patient, instead of having to go around and collect your records if you get that diagnosis, instead of you having to carry around, in some cases, boxes of your files, and then be responsible for every time you have to go to all your different doctors and pay for that information, carry it around with you to your specialty provider. This is really difficult for any parents of children who have acute conditions or rare diseases. I mean, the examples are kind of countless. It also, when we have a path and a method that everyone's following, even if the formatting is different, because of course nobody wants to upend proprietary tools and technology that make businesses profitable, but we do need to find the better path. At least this is what ONC's position is, to make sure that patients can say, hey, I want access to my information. I want to know what is behind that curtain so that I can better arm myself to get better care.
And is the long-term sort of goal of all of this, even going back to the legislation several years ago, that at the end user level, me as just a general consumer of health services, that I can go to a centralized place at some point, whether it's through the government, whether it's through my provider, and literally my entire health record will come up. It's been integrated. And what's the goal, I suppose, even if that seems quite challenging?
Sure. So that would depend on who you talk to, for sure. So I'll just offer a few different perspectives. So there is a perspective, and this is playing out through the Trusted Exchange Framework and Common Agreement, or TEFCA, wherein, yes, you would have a secure network. The goal in that case is to make sure that the security and compliance requirements are consistent. So in this case, it's high trust. Again, I hope most of you, if you're in healthcare, would be familiar with that, but that's NIST++, and that makes sure that the businesses who don't want to open up their systems, or there's so many increased cyber risks now. I think that's probably mainstream news, that you don't unnecessarily or unduly expose what is very private and sensitive information. In most cases, that's my opinion. That you have that framework in place so that the trust is there and the compliance is also there. And so in that instance, if you're moving through each of those networks, say, okay, we're all agreeing to move the information this way, so the rules of the road are well established, and that would make things, in that ideal future state, yes, if any of your providers who are participating with a vendor or an entity like a health information exchange, HIE, then yes, you could see that playing out. Here in Massachusetts, if you're getting healthcare, you likely don't think about these necessarily, because you do see your data moving. In places like California, it's more difficult, but they're doing a better job. In DC, where I live, I have doctors in Maryland, in the district, and Virginia, and even though it's my business to try and get my information in one place, that's not my priority. As long as I know how to get my kids' information and they're on Athena, and
Right.
my husband primarily uses Epic. Like, that should just, our position is there has to be a better way to move that information, as long as the consent, the patients know what they're consenting to, which we can, maybe touch on later when we talk about the impact of developers.
Sure. In terms of, I mean, I understand now why there was a 2-year glide path. I mean, what a monumental project. Let's talk about tech and innovation sort of as part of that process. What technologies did you use? What approach did you have in terms of trying to integrate all of these health systems into sort of a single sort of data repository?
So we want to give all the credit to the developers and the industry partners they're the ones that have been investing. And yes, you could argue, well, $30 to $40 billion invested by the federal government in the last 10 to 15 years, so that's not an insignificant amount of money. That developers of these products, in some instances, especially if you're supporting something like a federally qualified health center, they are using, the other side of the coin is you're getting paid to support providers using federal dollars.
Right.
So the onus of responsibility is on you to make sure your systems work as you say, because it's a voluntary program. So there are civil monetary penalties coming if someone accuses you of not making that functionality available, which is a very robust process that we are not responsible for. That's our partners, the Office of the Inspector General at HHS. But if you are using those federal dollars, then you need to be held accountable. You need to make sure that you are providing equitable care to patient populations that can't afford the luxury health record service providers who are doing amazing things, and there's many who have been way ahead of the curve for the past, especially in the past, I would say 8 years, but who can do this very readily because they were ahead of things, and they made sure that as it made sense to them, how can we meet that end goal without disrupting our business bottom line. So just kind of bringing it back, where there are still gaps, and I wouldn't go so far as to say yet that there's gaping holes, because I don't think we have enough actual hard data to show where those disparities exist. But we do and are seeing things play out, especially in some of the work we do inside of HHS with our partners. For example, HRSA is one that you may have read about recently. We're working with them to take the standards that we know work, and the process by which that information moves, to make sure that the health centers themselves can get access to that information, and then ultimately from the federal space, whether it's public health, research, social services, human services, there is a lot of people would say, well, the government better fund this because you're the ones that want the information, right? And it's hard to, it's a fine line that we're threading.
Do you see, in terms of with the data soon to be, secure, centralized, do you envision a wave of innovation if you're going to sort of open up the APIs for individual, almost like the app? I used to do a conference called App Nation on the app industry, and obviously the whole app revolution is based on sort of open APIs. Is that going to happen? Is it happening already? Do you see that as an opportunity to unleash innovation and get startups and developers involved with the open API accessing that information? I know people are very sensitive, perhaps even more about their financial information as they are about their health information.
Yeah, so great question. ONC recognizes this is complicated, and while our position as an organization is that patient, number one priority, get patient access to the data that they want and inform patients to their rights, but also what the concerns and the risks that they open themselves up to when they give permission. And this, again, it's when we're talking about your health portal and your health information, even if you're on Epic or you have an Apple Health integration to that portal, you as patients, like, forget about who you are in your business, you need to know that anytime you give consent to an app, whatever health app it is, that even in the fine print, you are, in many cases, not all, so I'm not going to speak for all developers and app developers or third-party apps, we don't yet have, there are very, very prescriptive, I mean, our regulation is thick, so this is why a lot of people don't know about ONC per se. But there are security requirements that, again, those developers, whether you're certified health or IT or not, will be expected to comply with. But you as the consumer need to know that the minute you check a box, you got to think about what that opens you up to. And certainly the last few months have demonstrated, whether it's from a cyber perspective or, you know, as a mother myself, that there's certain information that I know, me personally, I don't want all my providers to have access to.
Right.
And yet there's also a lot of examples, more all the time, where patients don't know that they have the right to make sure that all their providers can see their treatment notes, their prescription information, the risks they may have, back to the maternal health use case. A lot of women don't know that that provider needs to follow your care plan if you worked with your provider to put that and document it. Conversely, there are a number of complexities that need to be worked out still, and this is going to happen internally, internal to HHS, but also with industry partners. There's so much in health IT that's done as public-private partnerships, especially from a standards perspective. But it's your consent, and then also where the data breach could happen. So it's definitely not an easy. It's complicated.
And as all of that isn't enough, what else are you doing at ONC? I mean, there are many. You're coordinating with a lot of agencies.
Yeah.
You talked to me. Spent a lot of time coordinating with CDC and then the rest of HHS and the Inspector General, and it's a little bit of alphabet soup of the agencies that you're in. But talk to us about also integrating and working with the other agencies of the government.
Yeah, sure. So I think COVID was an amazing opportunity, and this is, you know, bipartisan perspective. Within HHS, there's huge organizations that have very big jobs just in and of themselves. So NIH, CDC, HRSA, FDA, and there was not an incentive or a need. In many cases, collaboration is time consuming. Coordinating with a number of different stakeholders, whether it's at a leadership level or at a staff level, takes a lot of time, and it requires patience and a certain skill set. So prior to COVID, ONC was kind of working on an as-needed basis, but now, because the convergence both of health IT, which again, not a lot of people have paid attention to before COVID per se, and I'm generalizing here obviously, and true information technology. So how is your cloud infrastructure set up, whether it's inside government or in the private sector? How is that then able to talk to a fire server, for example, which is where and how best that we've found globally, again, from a standards development perspective, the fastest way to move information securely and completely. So we're doing a lot with CDC, NIH, FDA. If you want to get into, you know, proof points about why standards matter, we have a RADx Mars. Again, it's like terrible, but I didn't realize before I came to government like how bad the alphabet soup situation was, or how creative it could be. Let's put it that way. So that is for at-home testing data. If a lot of states say, I don't want that information, I especially don't want it if it's garbage in, garbage out, and a mess for me to have to clean up on the end. But in this instance, we said, okay, let's get everyone to the table together first before one person and party runs off and creates requirements that not everyone can agree on and that maybe don't make sense from a practical, technical perspective. So let's take the time to do that up front, and then let's make sure that there's a way from a state perspective, for a state public health agency to say, yeah, I don't want that information, or, you know, turn it on or turn it off. So, and that does involve an end-to-end solution in many cases, whether it's public health, whether it's research, whether it's, you know, clinical care and measurement related. So that's taking time, but we feel really strongly that if you have those conversations up front about data quality and what information is most important to whomever the stakeholder you're working with
Right.
is, and that is not exclusive to our government partners. That's all of industry, as much as industry as we can get to the table. And that, again, back to the pharmacy example in COVID vaccines, there's a smart scheduling spec that was created before vaccines were readily available. So that was a way for, again, to use the standard to leverage it, make some modifications for industry partners to say, okay, this, Google was an example later that said, this doesn't actually make sense. You need to do better. Like, you need to go back to the spec and make sure it actually works for us to push out, because otherwise downstream you're adding a lot of cost and a lot of burden.
Right.
So how can we just do better togetger, no matter what the use case
No,
is? So
it's a monumental effort. Before we close, and I'm going to get the dagger from
yeah,
Caitlin
sorry.
over there. I'm going to run just 2 minutes over, Caitlin. I'm just going to let you know. Ritesh.
So riveting. I know everyone's
no,
like, I want to hear more about health IT.
Well, we do. It's important. It's $40 billion of our money, right, that's gone into this over the last 10 years. Ritesh has always been helpful at my past events talking about health data. We were maybe going to do this together, but we figured we'd streamline it. Do you have a question? Because I know you follow this very, very closely for Ryan. And I'll repeat your question.
Yeah, no worries. So, it's fascinating. We got people to digitize their offices, and then we got them to do standards, right? So you've got HL75 now out, and now we've got the open data rule. It doesn't seem to apply to the app developers, though. So, to an example, if we went to a concert, Clear was the app they used to verify that you're vaccinated. But when I read the terms and conditions, Clear had access, complete access, to my entire health record when I connected it to get to the concert.
Yeah.
For all of my data, health data, for 30 days. So do you see ONC going further into some of those domains? Because if we don't do that, then all of this is going to pay a provider.
Yeah, exactly.
And the question is, just in case you didn't hear, just about, sort of you go to a concert and Clear has your information for 30 days. We look at the T's and C's. And I guess it goes a little bit back into the open APIs and third parties. What's ONC's role there, or HHS's, or the government's, in terms of ensuring that? Because I don't know, that sounds a little sketchy to me, right? I wouldn't want that. But
So I won't comment directly on Clear. But no, the example is there's also something that was more of a representative body. It was called the VCI Initiative, and I'm sure you've heard about it. Dr. Brian Anderson, I'll just give him and his team a plug because they've done a ton of work on this globally, not for compensation, where that was a more lockdown version of the standard. Clear doesn't use the standard that the VCI developed and recommended. There's so many political sensitivities in many of these instances, but there's a blog post I think that was released today. It is pertinent and going to be critical. If you are a developer of a third-party app, it might not be, being monitored the way some of us would like to see now, but it's inevitable. Whether it's wearable technology, digital therapeutics, the definition, that's one of the things we're working through with FDA now. What is a diagnostic, what applies to that whole, set of regulatory requirements, what triggers it? And again, there's I think it's DS4P, very deep into the binder here. But I can't imagine that we as a country are not going to have to find a way to figure this out, because
the app stores, right? Maybe go to Apple and Google and say, if you want the health app in your store, these are the things they have to apply.
Yeah, and Epic has something called the App Orchard, and it's happening behind the scenes. You're gonna, like I said, we're gonna see more of this.
this is great. We could talk about this, and I wish we had you more than 30 minutes. But
we have lots of information.
We'll hopefully do this again in the spring. We'd love to hear how it's all going. I'm sure. But I know it's a very busy time, so thank you very much for coming up from DC. It's great to have you here. Thank you.